Okay. Hello, I'm Linden. I'm one of the subspec trainees in Leeds who does the joint cardiology clinic with the team. So a lot of this stuff I'll just gloss over because we're short of time, we've covered it already. But we know that women with congenital heart disease, things might get worse because of their pregnancy. And importantly, as obstetricians, we do prenatal counselling in conjunction with the cardiologists. But remember that new diagnoses are available in pregnancy. And because the increased work of the heart during pregnancy, you might find things that weren't there before. And therefore, when you're booking a woman, be you an obstetrician or a midwife, it's really important to ask about any cardiac symptoms that you think might be worrying, and particularly any family history of note. So if her brother died of a sudden unexpected death, it would be quite useful to know a little bit about that. And midwives are really well placed to do this because they take all the details when they're booking a woman in pregnancy. Again, this has already been covered a little bit, but we know that in pregnancy, because your estradiol levels go up and your nitrous oxide level goes up, all your peripheral resistance goes down, which means that women faint in the first trimester of pregnancy. It is normal. It is not usually worrying, taking into account the provisos that Dr. English discussed in her talk. Towards the end of the first trimester, your heart rate and stroke volume go up, which increases your cardiac output. These women become tachycardic from baseline. Again, that's nothing to worry about as long as you're used to looking at the typical obstetric patient Meows scores. So moving on to hypertension. So as I've said, your blood pressure at the beginning of pregnancy goes down and then it creeps up towards term. That is normal. But in women who have an abnormal blood pressure above 140/90, these women need treating because they're at risk of cardiovascular events, stroke, as well as developing preeclampsia. Particularly women to be very anxious about is women who have who've got previous coarctation, even those who've been operated on and appear to be well, because for some reason they still seem to be hypertensive in pregnancy. Remembering that when a woman's blood pressure starts spiking at 160/110, your obstetricians will start getting a bit panicky. So please don't let the women get to this stage. Thinking a bit about the women outside of pregnancy as well as inside of pregnancy, I think we sometimes get a little bit obsessed by the treatment of the blood pressure in pregnancy. But remember, long term, these women are really at high risk. And I don't think we explain this to them in clinic often enough. Over the course of their lifetime, they're at a hugely increased risk of having cardiovascular adverse events and strokes. So moving on to the treatment of hypertension and other cardiac problems in pregnancy. Always treat the mother first. I get loads of phone calls from medical registrars who are anxious about treating pregnant women for understandable reasons. And these two websites here are absolutely the best thing ever. The UK Tertiary Information Service and BUMPS, the best use of medications in pregnancy. And with every drug that we're prescribing for a pregnant woman, yes, we need to treat the mother. Think about how urgent it is to treat it, whether she really needs the drug. Statins in pregnancy aren't necessary. The timing of the drug, so when suits the woman, because women are reluctant to take drugs in pregnancy. And if you don't treat them at the right times of day, they won't take the drug because they don't want to anyway. They're a little bit worried. And if you make their life harder for them, then their compliance will go down. As well as thinking about, of course, the timing of different drugs in pregnancy, which I'll talk about in a second, and the lowest effective dose at any time. If a woman arrests in pregnancy, crack on with the standard ALS drug regimes. Don't worry about anything else. So this is probably a little bit small. This is taken from this paper from 2019, but it basically is an American paper. So it uses the FDA classification of how safe a drug is or isn't in pregnancy. The little dots on the far left-hand side next to the drugs represent how safe it is in pregnancy. The middle column is the FDA classification, A being best, C being worst, and then breastfeeding on the right-hand side. And I've just highlighted in green some of the drugs that we're very familiar with using and we know are safe in pregnancy. So for example, rate controlling, digoxin, flecainide, and these are drugs that we actually use in the fetus as well to rate control the baby, so they're safe. Hypertension, we tend to treat with labetal or nifedipine because they have good safety profiles in pregnancy. And then moving on to slightly more dodgy territory is women who are on ACE inhibitors. There is very little evidence to suggest that ACE inhibitors are teratogenic at all. They are definitely fetotoxic. They will definitely destroy a baby's kidneys. But if you've got a woman who's really well controlled or is in heart failure on ACE inhibitors when she conceives, we should be relatively reassuring to these women as long as they're switched over quite quickly during the first trimester. Now, moving on to a slightly different topic, another thing that obstetricians are obviously obsessed with is fetal growth, because small babies do badly and small babies die postnatally. So this is just a really nice chart here of the risk of babies, of mums with a congenital heart disease having preterm birth and being born early, either iatrogenic or because there is a problem with either the mum or the fetus. And you can see these women are high risk of fetal growth problems. So these women will need to have scans. Dr. Oliver touched on this a little bit, but these are the sorts of things that give me palpitations if a patient comes in the middle of the night. I won't go through them all again because he's done a beautiful job saying these are bad heart conditions in pregnancy. And again, like he said, this is a chart on the right-hand side of the maternal cyanosis, cyanotic condition and live birth rates. So you can see that if a woman has poor oxygen saturations of less than 85% at conception, then the chance of her taking home a baby is in the realms of 90%. Less than 90%, sorry. This is a nice little picture here taken from the Leeds website, so I thought I'd better share it, about women with Fontans circulations, which we've already talked really about maternal complications of, which I've listed up there, but we'll gloss over those because Dr. Oliver chatted about those already. But the fetal risks are really quite significant for these women, and of course, being obstetricians, we always have to think about both patients. These women have a high rate of miscarriage, and even if they survive the first trimester, the risk of having a late loss is still significant at 5%. That's 1 in 20 women. And these women will invariably get delivered early because we get twitchy or because the baby doesn't grow properly, 20%. Now, moving on again, women with Fontans are usually anticoagulated, women with metal heart valves are usually anticoagulated. And these are the three sort of broad ways of managing anticoagulation in pregnancy, which I agree aren't all ideal compared to the non-pregnant state. Option 1 is in women who are at high risk of clotting, we can just keep them on their warfarin. Some women are happy to do this, admitting that warfarin is teratogenic. However, it provides them with really good control of their anticoagulation, and it is dose dependent. So like we were saying a couple of slides ago, if you need to use warfarin, make sure it's the lowest effective dose and counsel the woman properly. Option 2 is to switch her on to clexane, low molecular weight heparin. This is safe as houses in pregnancy, but it does offer the woman less protection. And we mustn't forget that some of these risks are significant to her. CVAs, loss of limbs if she gets massive VTEs. And of course, don't forget about bone demineralization as well, and thrombocytopenia. And then the third option is obviously just to try and take her off her warfarin during the danger period, i.e. between about 6 and 12 weeks in pregnancy. And you need a really highly motivated, on-the-ball woman to do this, because she's only going to get a urine positive pregnancy test at about 4 weeks at the very earliest. So she needs to be on the phone to you to get switched over. This is great because it'll avoid teratogenicity, but as I said, it does require quite a lot of motivation from the patient. And these are the fetal risks of being anticoagulated. You can see here that warfarin throughout pregnancy actually has a lower overall fetal loss rate than being on fractionated heparin, which again, as Dr. Oliver said, isn't really something we do these days at all. And as he's already mentioned, you can't use the APTT in the 3rd trimester in pregnancy to monitor unfractionated heparin. For women who are on warfarin, talking about delivery is important with these women, because when are we going to stop the anticoagulation? Normally between 2 and 4 weeks pre-delivery, and you're going to have to bridge her. If a woman comes in unexpected labour, so of course these women might go into spontaneous preterm birth, then there is a risk of fetal complications and neonatal hemorrhage, which is something to consider as well. So when do we like to deliver our cardiac women? We've already discussed if the place of delivery needs to be coordinated such that it's in a tertiary centre, we'll obviously deliver these women a bit earlier, so there's no chance of them getting into spontaneous labour, so about 39 weeks, but as we've already said, by term usually. Sometimes that is expedited by deterioration of mum. She might need admitting to hospital for monitoring and then bringing forward the birth. And obviously, if the baby is starting to struggle or she develops preeclampsia, that might twist our hand. In terms of mode of birth, Dr. Halsley talked very nice about cesarean sections and how we manage that. But we see a lot of women who quite rightly want and should have a vaginal birth. And there's a lot of debate about how best to manage these women, and no one really knows the right answer, so feel free to do research in this area. We generally recommend an increased passive stage of labour, i.e. so when a woman should be pushing in inverted commas when she gets to fully dilated in labour, if she's got a beautifully working epidural because the obs anaesthetists have been round, we generally recommend that they extend this period a little bit more than for your average woman before she starts pushing, because we think it probably reduces her pushing time. However, more recently, a study of over 100,000 Dutch women was done and actually suggested that maybe increasing the passive stage doesn't really shorten the length of the overall birth process. So who knows? But at the moment, it seems sensible. We always are concerned that a repeated Valsalva manoeuvre in labour might cause hypertension, which is particularly women in those Fontans women, particularly worrying in those Fontans women we were talking about. But again, this isn't actually borne out by clinical practice. So again, we're a little bit sceptical as to what best to do. We know that pushing increases your cardiac output, your heart rate goes up, but the ROPAC says that actually the rate of arrhythmia doesn't go up during the pushing stages of labour. And actually studies have implied that the maximum work of the heart is done when you're about 8 centimetres in labour. So whether or not we worry too much about the pushing is yet to be shown by studies. We've already talked about place of delivery, be that in a tertiary unit or in the women's local unit. And we've talked about place of birth. Dr. Housley did that very nicely. There's just one very quick case history here. I won't labour the point. It's mainly about medication and pregnancy. So this is a lady who's got a high BMI. She's got pre-diabetes. She's had 2 previous babies. She's got hypertension controlled on lisinopril. She, in her previous pregnancies, has had pregnancy-induced hypertension and has remained hypertensive postnatally. She saw a GP with shortness of breath and palpitations who referred her into cardiology. You can see the results of the echo and the 24-hour tape then. They did a urine dip and of course she was pregnant. So at home, her average BP readings were high. So she was a little bit poorly controlled. So basically, the main things to think about, what we've talked about so far, is we need to switch her over from an ACE inhibitor. She's still in the first trimester, shouldn't be a big problem. Ideally to nifedipine, it works well. She needs to get better control of her own blood pressure. We need to educate her about why it's important. She's going to need growth scans. She's at risk of developing preeclampsia, so she needs to go on aspirin. And we can do uterine artery Dopplers at about 22 weeks to try and predict her risk of developing hypertension later on. So in general, she needs better she needs better control for end organ protection for the rest of her life. And don't forget to tell these women they should have annual blood pressure checks with their GP, even if they don't get persistent hypertension post-delivery. That is all. Thank you very much.